Okay, now we're going to move along to looking at errors in study design. And more specifically, we're going to look at the types of errors that can occur when we're studying or we're conducting a randomized control trial. So to put this section in context, we're going to have to discuss validity and precision first. So validity is essentially the absence of bias or systematic error. And precision can be defined as the lack of random error in a given study or statistical error. So with these two definitions in mind, overall error that can occur in a study, so error just meaning we get the wrong answer to our study question, or we're not able to properly determine whether our hypothesis is true or not. Error is made up of random error and systematic error. So this is more related to validity here, and random error is more related to precision. And in the next few slides, we're going to really focus on systematic error. So systematic error is also called bias, or if the systematic error is occurring, it's called bias in a study. And bias is made up of three separate systematic errors called selection bias, confounding, and information bias. And I'm going to go into each of these three biases right now in a little bit more detail. So the first bias we're going to talk about is confounding. So I alluded to this a little bit earlier in the lecture when we were talking about randomization and how we want to make sure that study characteristics or patient characteristics are equally balanced between the intervention and control groups. We want to make sure that our intervention group patients are nearly identical to our control group patients in order to ensure the only difference between the two groups is the intervention. So we can actually test the effect of the intervention on whatever outcome we're looking at, independently of the patient characteristics in between the two groups, because those are held constant. So what we want to look at or think about when we're looking at confounding is whether or not there are actually differences in patient characteristics between the two groups. So confounding occurs when there are differences in patient characteristics between the intervention and control group. And this can occur when risk factors or patient characteristics are unevenly distributed across the intervention and control groups, making the two groups incomparable. So examples of confounders are patient characteristics that tend to be associated with the outcome that you're looking at, or the risk factors for the outcome. And that's what we start off with when we start to look at a set of characteristics that could be confounders. So in this example here, we're looking at the association between a particular diabetes medication and myocardial infarction. So we're comparing two different diabetes medications to see if there's an increased risk of myocardial infarction with one diabetes medication over another. But a confounder for this particular medication outcome relationship is hypertension, because hypertension can also be associated with myocardial infarction or is a risk factor for myocardial infarction. But if the prevalence of hypertension is not equally distributed between, or is not equal between the intervention and the control group, then confounding can occur because the two groups are not comparable with respect to the prevalence of hypertension. We want the prevalence of hypertension to be the same in the intervention group and the control group if we're looking at the effect of different diabetes medications on myocardial infarction. Hypertension is the confounder or the patient characteristic that's not balanced between the two groups. And when it's not balanced, this leads to confounding. So there's ways that we can prevent confounding in randomized controlled trials at the study design phase. So of course, as we talked about earlier, randomization is a way to ensure both the control group and the intervention group are similar with respect to patient characteristics. We can use restriction. So this means that we remove patients with certain characteristics from our study population, and that will remove the effect of confounding. And we can also do matching. So we select individuals with identical characteristics to analyze. So those are ways we can prevent confounding at the design phase in an RCT. So moving on to the next bias, which is information bias. And information bias is all related to, it's typically related to confounding, or not confounding, sorry, it's related to mismeasurement or misclassification of outcomes or exposures or other variables that are being measured in the study. So it's related to inaccurate measurement of patient characteristics, including the exposure variable or the outcome variable, as well as other important risk factors or confounders in your study. So information bias can occur in a randomized controlled trial if blinding is not effective. So if an investigator knows that a patient is in the intervention group and not in the control group, they might actually record outcomes differently because bias is introduced. And if a patient knows if they're in the intervention group or the control group, they might also report subjective outcomes a little bit more differently if they're aware which group they're in. So, for example, they might, if they know they're in the intervention group, they might report pain levels that are actually lower than in reality because they have this perception that the study medication might be helping them more than it actually is to manage their pain. And so this is all related to, variables that are collected in the study not being accurately collected because of patients or investigators knowing whether patients are in the intervention or the control group. So in order to prevent information bias in randomized controlled trials, it's important to use standardized assessment tools or rubrics in order to minimize the possibility that study information can be mismeasured or collected improperly or reported improperly. Repeated assessments by different study investigators means that you're more likely to get an accurate measure for a patient characteristic if it's measured multiple times. Parallel assessments for both groups means that the assessments are done separately for the intervention and control group patients for different with different investigators, so it's a little bit more standardized within the group. And it's also, like I mentioned, important to blind those for measuring the outcomes so they don't actually mismeasure the outcome or over or underreport the outcome or other patient characteristic due to the knowledge that the patient is in the intervention group or the control group. So lastly, the last bias we're going to discuss is selection bias. So selection bias is mainly related to who we include, patients that are included in the study at the end of the trial, and then how they're included. So selection bias can result from procedures used to select patients, as well as factors that influence study participation. So these factors then lead to a bias. That means that the exposure and the disease relationship is different between those who participate in the study and those who don't participate in the study. So I know this definition is a little bit confusing, but I think it'll make more sense in the next slide when we talk about how bias occurs or how selection bias occurs in randomized controlled trials. So the most important way that selection bias occurs in randomized controlled trials is due to lost follow-up. So you start off with a group of study patients in your trial, and then over time, patients might differentially drop out of the intervention and the control group. And this can be especially problematic when there's differential loss to follow-up between the intervention and control group. So differential meaning there's a reason that patients in the intervention group are a characteristic or a side effect associated with dropping out of the study that's due to the study medication. So this could include something like a side effect of the medication. So patients in the intervention group are experiencing a side effect and then they drop out of the study and they're no longer followed or included in the study, and the control group patients are. So this is called, as I mentioned, differential loss to follow-up between the intervention and the control group. And this can lead to a selection bias because the patients who were in the study at the start of the study in the intervention group are no longer representative of the patients who are at the study at the end of the study, and there's a certain group of patients missing from our study population out of the intervention group. It's those who experienced a side effect of the medication. So then when we're trying to compare the effect of the intervention medication on the outcome compared to the comparator, we're going to get a biased result because our study population is now biased with respect to the sample we're analyzing at the end. The selection bias can also occur if allocation of treatment is not concealed. So if patients are aware that they're in the control group, again, they might drop out of the study at a differential rate than the intervention group patients because they're no longer interested in participating. So again, this is related to a loss to follow up and a difference between the groups of patients that are initially randomized to the intervention or control group at the start of the study compared to the patients we're analyzing at the end of the study and at the end of the follow-up. And we really need to think about, which patients have we lost to follow-up during the course of the study? And do these patients have different characteristics compared to those patients who have remained in the study? So that is a quick overview of selection bias. So again, if you have any questions about the material that I just covered, please post them in the posts page on MS Teams, or you can bring them up during the trial seminar in class. So thank you for your attention, and I'm looking forward to discussing these topics in more detail in the seminar.